Hello, myself Protoybala Tultul. Welcome back to the another new video. Today I will discuss about a new topic which is called hyperbilirubinemia or jaundice. Jaundice or hyperbilirubinemia is an excess of bilirubin in blood which causes yellow discoloration of the neonate's skin, mucous membrane and sclera. Hyperbilirubinemia is an elevated level of bilirubin in the blood. It makes the baby's skin look yellow. Jaundice. Neonatal hyperbilirubinemia is often a transient benign disorder occurring during the first week of life. It is often a clinically significant, however, and does require follow-up to ensure that it is self-limiting. As bilirubin level rise, the excess bilirubin is disappointed in body tissues, resulting in a temporary yellow discoloration of the neonate's skin and sclera. High bilirubin level can penetrate and damage brain cells, a condition referred to as herniatus. Next, cases of hyperbilirubinemia. Important cases of neonatal jaundice based on age of onset are given in the below. First day, RS and ABO incompatibilities. Intrauterine infection like toxoplasmosis and cytomegalic inclusion disease. G6PD deficiency, hereditary spherocytosis, drug administration to mother, homozygous alpha thalassemia. Second and third day, physiologic hyperbilirubinemia of newborn, birth asphyxia, cephalthoma, acidosis, hypothermia. Hypoglycemia, drugs, familial non-hemolytic icterus as in Crigler-Najjar disease, Gilbert disease, Dubin-Johnson syndrome. 4th to 7th day, septicemia, syphilis, toxoplasmosis, cytomegalic, extrahepatic atresia of bile duct, breast milk jaundice. After first week, septicemia, extrahepatic atresia of bile duct, hereditary spherocytosis, neonatal drug-induced hemolytic anemia, galactosemia. Persistent jaundice during first month. Inspired bile syndrome, cretinism, congenital hypertrophic pyloric stenosis. Risk factor of severe hyperbilirubinemia. Major risk factor: pre-discharge total serum bilirubin (TSB) of transcutaneous bilirubin (TCB) level in the high risk zone. Jaundice observed in the first 24-hour. Blood group incompatibility with positive direct antiglobulin test. Other known hemolytic disease, ex- extended end tidal carbon monoxide content in exhaled air. Gestational age 35 to 36. Previous sibling received phototherapy, cephalohematoma, or significant bruising, exclusive breastfeeding, particularly if nursing is not going well and weight loss is excessive. Minor risk factor: pre-discharge TSB or TCB level in the high intermediate risk zone. Gestational age 37 to 38 weeks. Jaundice observed before discharge. Previous sibling with jaundice, macrosomatic infant of a diabetic mother, maternal age less than 25 years, male gender. Next, come to the type of jaundice. There are two types of jaundice, such as physiological jaundice and pathological jaundice. Physiological jaundice. Physiological jaundice represents physiological immaturity of the neonates to handle increased bilirubin production. Visible jaundice usually appears between 24 to 72 hours of age. It does not require any treatment. It defined as jaundice in healthy babies during the first few days of life due to physiological reasons. It appears on second or third day of life. Rise at disappears by 10 to 14 days of life. Next is pathological jaundice. Pathological jaundice is referred to as an elevation of TSB, total serum bilirubin levels, or to the extent where treatment of jaundice is more likely to result into benefit than harm. Neonatal jaundice is considered pathological if it appears on day 1 of age, persists beyond 2 weeks, total serum bilirubin level exists 15 mg per deciliter, or conjugated serum bilirubin level is more than 0.5 ml per deciliter, or 20% of total bilirubin. Rise in serum bilirubin level is more than 0.5 mg per deciliter per hour, or associated with sign of illness. Now we see the difference between physiological and pathological jaundice. Physiological jaundice appears on second day. Pathological jaundice starts on day 1. Bilirubin level rises slowly. Jaundice lasts longer than 14 days in terms of 21 days in preterm. Level rarely goes above 15 mg per deciliter. A rise of serum bilirubin level over 0.5 mg per deciliter per hour, or 10 mg per deciliter per day. Baby remains otherwise healthy. Jaundice with sign of sepsis. Jaundice clears spontaneously within 7 to 10 days of life. Jaundice extends up to palm and soles. Jaundice with pale stool. Next one is complication of jaundice. The brain toxicity can either be reversible or irreversible. Cerebral palsy, deafness. intellectual impairment. Characteristics, a type of brain damage. Now see the nursing intervention or management of jaundice. The nurse should frequently observe and detect any early change. The general condition and alertness of the neonate should be noticed. Vital sign also should be maintained. The skin color is observed for the increase or decrease in yellowish. The urination is checked for the frequent amount and color. Any behavior change, convulsion or sluggishness should be noted and reported. The normal body temperature should be maintained, especially when the baby is under phototherapy. Adequate fluid intake is necessary to help in the excretion of bilirubin, and intake output should be closely monitored to ensure adequate hydration. When the neonate is under phototherapy, the eye of the neonates must be protected from the light. The neonate is removed for a short while from the phototherapy for breastfeeding, eye contact with the mother, emotional support, and for tactile stimulation. Thanks for watching this video and please subscribe my channel.